Perfect. Great. Okay, so today we're going to talk about the key components of a burn assessment. We'll look at care priorities, both initially and then for those patients requiring ongoing burn treatment. We're going to talk about some common burn dressings that you may see, and then identify possible complications following injury. Okay, sorry, bear with me as I attempt to advance the slides here. Okay, very good. So when we talk about epidemiology, about 280,000 pediatric burn injuries occur annually, and these would all be injuries that are requiring some type of medical attention. At Children's National, last year in fiscal year 24, we treated 927 unique patients who accounted for over 2,100 visits to our institution. So kids are different. Kids have slower reflexes, thinner skin, a higher risk for hypothermia, and a higher BSA, body surface area to weight ratio. And we're going to go over all of these concepts in a little more detail, but again, kids are different than adults. Who has the trauma burn app? Does anyone have access to it? Yeah, okay, very good. Guys, take a look at this. I would love it if you downloaded the Trauma Burn app. So this actually has all of our policies, protocols, algorithms. Super, super helpful, especially for you all working in the ED. So this is a free download. You'll be asked to register with your role. So nurse, ER nurse, critical care nurse, acute care nurse. And then once you register, we'll have to confirm your registration as an internal employee. But again, this is a great resource for all things trauma, all things burn. Highly recommend that you download this. So when we talk about a burn injury, we're going to talk about the following. It's going to help guide us care for the injury. We're going to talk about how it happened, how intense or hot was the substance that the skin was exposed to, or the duration of exposure. We'll talk about when the injury happened, where it happened. Again, BSA, total body surface area. You're going to hear that concept a couple of times during this talk. And then how deep the injury is. And again, this is all going to guide the disposition, the care, the home care, et cetera. So when we talk about how the injury happened, what was the mechanism? Was it scald? And that's the majority of what we're going to see in our population. Was it a chemical burn? Was it a radiation burn? Was it a treadmill injury? We'll talk more about treadmill injuries as well. And again, intensity and duration. The burn depth is directly related to both the mechanism and the amount of time the skin is exposed to the source. So this is an example of how quickly hot water can injure the skin. So we recommend that bath water is about 100 degrees Fahrenheit. So hot water heaters really should be set at about 120 to allow for safe bath water. As you can see, once water reaches that boiling point, it can burn skin in a second or less. So question for you guys, which hot liquid is associated with the deepest scald burn? Tea, bath water, or coffee? Who thinks it's tea? Bath water. Okay, coffee. We actually see tea most often. Sorry, let me go back. So tea. Usually tea is boiling water. Usually tea is steeping on the counter. Little one toddles over. They grab that hot cup from the counter. And again, a lot of times we'll see a more deep dermal injury. I don't know about you guys, but usually my coffee is not hot by the time I have a chance to drink it. But in general, tea burns are usually associated with more deep dermal injury. Here's a tip too, if a kid is coming into the ED and you see extensive facial burns, I would advise you to look for a clear area of demarcation. What does that mean? See if the burn extends up into the hairline. If you can't see where that burn injury stops, there's a really good chance it's going to extend to and through the scalp, throughout the scalp, which actually can make a burn that seems like a smaller injury much larger, so it's going to add to that total body surface area. And this is something we really need to ensure that we have good sedation to take care of, because we need to actually give them potentially their first haircut. And that's really hard. We certainly don't want to do that in our outpatient clinic. So this child may require sedation in the ED or even an operative debridement. Okay, contact burns. So those scald burns account for about 40 to 50% of what we see in the pediatric population. Contact burns are about 30% of what we see. And we talked about kids having slower reflexes. So an oven at 350 degrees, little one toddles over, puts their hands on top of that oven. They don't have that reflex to pull back. So that could be a deeper injury. Similar with a curling iron. It's set at 400 degrees. They reach for it. They don't have that reflex to immediately drop it. So again, could lead to a deeper dermal injury. And then finally, flame burns. So we don't see it that commonly, but when we do, it's with our older kids. It's kids who are playing with matches, or perhaps there's a seasonality to it, and we see patients get too close to a grill or to a campfire. And here's a tip as well. We talk about singed eyebrows or singed nares. What are some signs that there could be inhalation injury? Well, I will tell you that inhalation injury is only going to happen if you're exposed to flame in an internal space. If you get too close to a campfire, there's really no chance that you're going to have that severe inhalation injury that you would have involved in a house fire. So again, only in enclosed spaces are we worried about inhalation injury. So chemical burns. A common thing that we actually see is when a kid goes to a pediatrician and has a wart, we use a chemical to help dissolve it, if you will, and sometimes the surrounding skin can be injured. So that's a common chemical burn that we see. Also, we may see kids getting into household agents, so bleach, things like that. So we don't neutralize, we don't use neutralizing agents. We'll want to make sure that we flush the burned area with lots of water, call poison control for additional guidance, and then we just treat the depth of the burn. So electric burns, those caused by low voltage injuries would be an example like a little one sticks a bobby pin into an electric outlet or a paper clip into an electric outlet. So the important differentiation here is that this is household current, so less than 240 volts. This is very different than the Pepco worker working on wires. Again, this is very low voltage. So if this occurs, these children do not need an EKG. They don't need urine myoglobin checks or CPK. We just treat that cutaneous injury. Usually it's a little bit of bacitracin, and then they would follow with a pediatrician or with our clinic only as needed. In that app, once you download it, you can find not only our electric injury algorithm for low voltage injuries, but certainly for high voltage injury as well, and that's a different playing field. I told you we talk about treadmill injuries. So treadmill injuries are also pretty common. We're quite versed with treating these. It's a degloving injury. If a patient is, experimenting, seeing how fast they can go running on a treadmill, just bumping up that speed and happens to fall, sometimes we'll see knee injuries or chest injuries or facial injuries, but oftentimes the little one is climbing on a treadmill. The treadmill turns on, and then again, it's a degloving injury to the hand. We're going to treat these with a daily dressing, plus minus an X-ray if we think there's a crush injury component. And then time from injury. So this is important in the major burn to determine fluid resuscitation. There are major fluid shifts in large burns in the first 24 hours. But also we want to identify burn progression. So what does that mean? If anyone has had too much sun exposure and gone to bed and then woken up the next day with a bad blistering sunburn, that's burn progression. Usually these injuries take 48, 72 hours or so to show us what they've got. So again, something could just appear to be just some pink skin, and then the next day you see blistering, you see evidence of a second-degree burn. We also want to make sure that based on that sentiment, that care is sought in a timely manner. So again, it could be completely reasonable that the child is exposed to a hot liquid, the skin is just a little bit discolored, and the next day the parents notice blistering or bulla developing, and then come in for treatment. Totally plausible. Again, we just want to think in the back of our minds about treatment being sought in a timely manner. And then location. So this is going to guide everything from our treatment to our disposition. So I just kind of want to go through these pictures real quick with you. So the first baby with a burn on the posterior torso on the back, that looks like a pretty superficial second-degree injury. We see blistering, we see nice pink skin underneath, and that would be a perfect candidate for an ER debridement, sending them home in a long-acting dressing. The parents wouldn't have to change for 5 to 7 days. They'd come back to see us in clinic, and hopefully things would be close to being healed in an ideal world. So that patient is perfect for at-home treatment with over-the-counter analgesics, just making sure that they keep up with their nutrition and that the dressing stays nice and clean. What is worrisome about that hand? What would you be worried about? What was that? Yeah, no, definitely. Joint involvement, that's always concerning, right? Because especially hands tend to contract as they heal. So we want to make sure that we get early occupational therapy involvement for stretching, for splinting if needed. So definitely joint involvement. What else? 100%. Where is that swelling going to go? There is nowhere for that swelling to go. If you hear the word circumferential injury, that this is classic. This is what you should think of when you hear circumferential injury. There is nowhere for that swelling to go. This looks like a hand that was submerged in hot water. Intentionally, could be unintentionally. That's to debate later. But again, there's nowhere for that swelling to go. So we really have to make sure that we're keeping a close eye on neurovascular checks. That burn is going to swell. Remember, I talked about burn mean progression in 24 to 72 hours. We need that hand strictly elevated, good neurovascular checks. And again, that's a potentially concerning mechanism. So we want to make sure that we investigate this a little further, get a social work consult, CAPC consult if necessary. And then, say you're working in the emergency department, you and your team do a nice debridement of this little one, still scald burn. Would you admit that kiddo or send him home? What do you guys think? Who would admit him? Who would send him home? Okay, I think I think we're all pretty much on the same page with admission. So I do have a black box of the child's face, but that's a significant facial burn, and facial burns are tough. Again, they're going to be prone to that swelling that's going to be greater at 24 and then 48 and probably 72 hours. A lot of times the eyes will swell shut. And again, it's tough to look at. It's super upsetting for the parents, for the kiddo themselves. And these actually require twice daily facial care. That's a lot that we're asking the family to do at home. It would seriously behoove them to come into the hospital, get comfortable with facial care, and then continue that care at home with close interval follow-up in our clinic. Now, I will say, on the flip side, facial burns are amazing. There's such good blood supply, such good vascularization. They almost all heal within 1 to 2 weeks. So they heal really quickly. But again, the skin on the face is so thin that they're prone to injury. And now, the importance of estimating burn size. So greater than 25% total body surface area, that's a quarter of a child or a patient's skin being injured, is a trauma activation. More than 40%, so almost half of the body surface area, requires burn attending presence in our trauma bay. Quickest way to see how big a burn is to take the child's entire palm, including fingers, and that's 1%. So sometimes our team will do this because there are a couple of quick decisions we need to make when a child presents with a burn injury. Number one, if it's more than 15% after we do the debridement, after we do the cleansing, that child needs to go to the ICU for fluid resuscitation. If it's between 5 to 10% or 5 to 15%, there's a slim chance the child could go home if it's a 5-6%. Otherwise, we're pretty much looking at the child being admitted to the hospital. So again, really important, as I said, for disposition. So I've seen this done a couple of ways. You could take the child's hand and see how many of their hands fit in yours, and pre-debridement, kind of get a quick guess of, do we need to admit it or not? Do we need to call the ICU or not? Or I've seen even some of our residents like trace the child's hand and then use that as their calculation. So again, it's a really good concept and a quick tool to make that initial assessment as to where that patient needs to ultimately be treated. We also have, so not only the trauma app, but this is another free app I'm going to advocate that you all download. It's called Easy TBSA, and if you are in a place that you're treating burn patients, again, like the emergency department, or even on the floor or critical care, this app is tremendous. So you download said app, post debridement, so after all of that skin is cleansed and you have a clean wound bed, we take pictures for the chart. And then we use this tool, and we plug in the patient's age as well as their weight, and then outline the areas that are injured. And this gives us a calculation of how big this burn injury is. And again, a lot of how big the burn injury is dictates where they'll ultimately go. Is it home? Is it the floor? Is it the ICU? So just to summarize, our priorities are making sure in that initial trauma assessment that our ABCs are intact. We'll want to do a quick primary survey as well. We want to make sure that we're providing oxygen if needed, especially for the sicker patient in the trauma bay. We want to make sure that we have IV access, both for our fluids and for pain medication. And then we'll go through a secondary survey and a pre-debridement TBSA. So this is just kind of major concepts in the care of the major burn patients. So when we talk about how deep a burn is, burn depth, we want to talk about how deep the injury extends into the skin or the dermis. So you'll see that superficial injury is really just the top part of the skin that's injured. Superficial partial thickness goes a little bit deeper into the dermis. And then you see that full thickness injury goes all the way below the hair follicle, the sweat gland. So really, if, almost down to the fat, if not down to the fat. So you'll see if you don't see hair follicles, that's not a good thing. That definitely indicates a deeper burn injury. If you see very pale tissue, again, that could be indicative of full thickness injury. Now, everything will heal, but you want it to heal with good skin. So the best predictors of healing are those injuries that are superficial or superficial partial thickness. As it gets deeper into the dermis, it's going to take longer to heal and may leave a crummy scar. So, superficial burns. These are characterized, it's basically a sunburn, so just that top layer is damaged. These are pink, there's erythema present, they blanch, uncomfortable for sure. These will heal spontaneously within 1 week, and we would recommend follow-up with the PCP only if needed. Sometimes this does come into the ED, but again, shouldn't prompt a surgery consult or anything like that, just supportive care and discharge home. This is everything that we see though. Superficial to deep partial thickness injuries, or your traditionally second-degree injuries, are very, very common in kids. The spilled scald mechanism is, again, kind of like our bread and butter. It's kids who are less than 2 most commonly, and again, a mechanism like they go and that tea is steeping on the kitchen counter, they go over, they're curious, they grab it, and then sustain a burn injury. So these superficial partial thickness burns are characterized by skin that's pink, it's moist, it's blanching. Of course, all burn injuries are going to hurt. These heal, though, within 1 to 3 weeks. And actually, the healing time is the only definitive way to tell how deep an injury is. So if a kiddo's healed in a week, terrific. It's a superficial partial thickness injury. If it's more like 3 weeks, I would consider that a deep partial thickness injury. So a lot of times, kids come in injured to the ED, and parents immediately ask about scarring. A good party line would be, right now, the burn certainly appears to be a partial thickness injury. We're going to watch the injury closer, and we'll have a better idea as the wound heals of the type of depth that it is, something like that. These burns that heal in less than 21 days or less than 3 weeks really do have good outcomes. It's a lot of what we see, and a lot of these kids have little scarring, little hypopigmentation. So here's another example of a superficial partial thickness injury. Again, pink, moist. If you touched it with a gloved hand, it would be blanching. So superficial partial thickness injury. Now here's an example of deep partial thickness injury. Maybe this is a T-burn. We talked about T-burns being some of the deeper dermal injuries that we see. So I would characterize this burn as red in color. You can also see some pallor centrally. You see those polka dots. We would describe that as capillary burst. These usually take 3-6 weeks to heal, and oftentimes do leave a scar. And we've definitely got scar mitigation techniques there after the injury heals. But again, just something to keep in the back of your mind. If we're seeing this wound, for weeks, we're getting to that 2-3 week mark in clinic. We're probably going to talk to the family about some scar mitigation techniques as well. And then finally, full thickness injury. These are your flame burns. This could be a really nasty treadmill burn. These, you'll know them when you see them. They are white, they are brown, maybe black. Most likely will require an operation, some excision and grafting to get rid of that skin that goes or the injury that goes all the way through the dermis, where we can put fresh skin or a skin graft. So it used to be that that the general surgery team would be called every time there was a burn injury. As you all in the ED know, you have so many experts, trauma technologists and EDPAs and NPs and your attendings, that really the surgery team should be called for burns involving specialty areas or burns that are more high risk, maybe in need of admission. So we do have this also on your trauma app if you wanted to take a closer look at the guidelines, but these would be indications to call our team. Other things I want to point out here, if there's a concern for non-accidental trauma, we'd like our team to be involved. If we think that it's a deeper injury, maybe in need of operating room excision, a fever, I want fevers admitted, burns, immunocompromised children, so we want to make sure that we're making sure that we support them and keep a close eye on them if they are running a fever, or a request from the family to be seen by our team. So are you guys familiar with burn casts? Trauma casts, burn casts? Okay, very good. So we have a number that are quite helpful. This is a nice one, again, for our ED providers here. Burn casts, when they originated, were really directed to the bedside nurse with common questions and things that you might encounter in the care of the burn patient. And then we decided, because that we wanted to expand our audience, that we should make some that are provider-based as well, or specific to providers. So this burn cast, episode 17, burn debridement and dressings in the ED, is really geared to our resident team, to providers in the ED, but again, good concepts really for anyone at the bedside taking care of burns in the ED, with just some helpful tips. So I would love if you guys would either snap this QR code or just take note. This is a good one for those of you working in the ED. So we get that burn consult, and we know that we need to treat the burn. What are the steps in doing so initially? Now, first thing we want to do is ensure adequate pain control, and we have a number of agents to do so, anywhere from intranasal fentanyl to IV medications to potentially sedation or anesthesia. Why is this so important? It's so important because these hurt. These injuries are painful. So maybe it's a dose of ibuprofen at triage for a high pain score. That might be something that we can start with, or maybe in the trauma bay, we start with a quick dose of intranasal fentanyl while we're getting lines. This is incredibly important. Studies show that children with improperly controlled pain in those initial hours following injury are hyperalgesic. So they're going to have a heightened pain response. So again, critical concept here. The next thing we're going to do is prepare for a debridement. And debridement means wiping away all of that injured skin in an effort to see, again, the extent of injury, how deep the injury is, and to provide a clean wound bed. So this first example here is a kid's knee, obviously. And if you can take a deep look, like there's like a hair in it, like it's gross. Kids also, you'll go down and you'll have a burn patient coming in and you'll see they have a burn to the chest and they're drooling on it. So again, we want a clean wound bed. So that's the first reason that we clean. And then again, secondly, we want to make sure we want to see how deep the injury is. That's going to guide how we treat it. This next kid actually came to me in clinic. He was treated at an outside hospital for a palmar burn, and he was being treated with Silvadene. But what good was it doing if he couldn't close his hand or if there was this pre-existing blister? So we took him to the ED, did a good, nice debridement, a sharp debridement, got rid of all of that blistered skin, and then we had a clean wound bed that we could treat appropriately, and then make sure that we restored function. We love pre and post debridement photos as well in Cerner, in PowerChart, and again, it just shows us over time how these injuries heal and evolve. And then the next step would be to apply a burn dressing, and these are some common dressings that we see. So kind of going in a circle here. So we love Silvadene. Silvadene is great for road rash. It's great for a treadmill burn. It's great for a wound that might look infected or just needs some antibiotic. It has sulfa in it. So Silvadene is silver sulfadiazine. Downside is it's a daily dressing change. So that would be tough for a family to do, especially when an injury is so fresh. But it is one adjunct we can use. Sometimes we'll use it on deeper burns for admitted patients, but it's something that you certainly may come across. So moving around, next is bacitracin. So also topical antibiotic. This is great for the diaper area. I really like it in the diaper area because it's practical. If a little one has burns in the genital region or the diaper area, with diaper changes, you can just clean, apply more bacitracin, plus minus Xeroform as well. Sulfamylon you may see to a deeper dermal injury and ears as well. It penetrates the ear cartilage quite well. Aquaphor we use for all facial burns and for injuries once they're definitively healed. And as I said, Xeroform is really nice. It's a nice adjunct. It helps keep bacitracin in place if that's the topical antibiotic we choose. We also like Xeroform on faces. It provides a nice moisture between those twice daily cleanings. And then this is probably the most common thing that you'll see, especially in the ED. Methylex AG is a long-acting silver impregnated dressing that is really, really light. It's slightly absorptive, so it can absorb some of that exudate, and it's gentle when it's removed. So love Methylex. So in summary, a minor to moderate burn, so something that doesn't need to be admitted, so ideally less than 5–6%. We would debride with wound cleanser. We're going to go ahead and dress it with one of those aforementioned dressings, most likely Methylex AG. And then our emergency department will prescribe the child, if they're greater than a year old, and it's a more significant burn, 0.1 mg/kg of oxy to be taken prior to that burn clinic visit. ED then emails our team, and we get that child in. This is also the referral number for outside hospitals or pediatrician offices, et cetera. And we also have after the burn videos that we share the link with to the families, and those cover everything from dressing changes at home to how to get to burn clinic, types of burns, et cetera. So here's a nice example of that oxycodone prescription. And again, my plug, if it's a bigger injury, especially in a younger kid, an infant, less than 12 months old, less than 2 even, we may want to consider admission for a long-acting dressing. If we do admit burn patients, there's a burn surgery admit plan that goes over everything that a burn patient might need, between PT, OT, and child life and social work, to vitamins, to nutrition orders, et cetera. So that's a nice summary of things that we need in that care plan. In terms of fluids, we don't like boluses. There's a lot of fluid shifting in those first 24 hours, especially in the bigger burn patients. So really maintenance fluid is fine if a burn is less than 15%. But if you do your quick down and dirty and you see that TBSA is probably greater than 15%, totally, and I need to go to the PICU, totally fine to start lactated ringers at 1.5 times maintenance until we get them upstairs, and then we can do fluid resuscitation, et cetera. So again, care priorities and that initial management include pain management, a pre-debridement TBSA estimate, coverage with the dressing of choice, and then IV fluids, no bolus. We have this poster hanging in our trauma bay in our code room, and this describes management of burns that are more than 15%. So again, 15% is that magic number. 15% or greater needs to go to the critical care area, to the ICU. So in the ED, we're just going to do a few things. We're not going to do huge dressing changes, debridements. We're just going to get that pre-debridement TBSA. As I said, 1.5 lactated ringers, clean sheets, get them upstairs to the ICU within 60 minutes. Once we get upstairs, we've got a ton of work to do. We need to place lines. We need to make sure that we have adequate analgesia. We want to plan for sedation. We want to plan for debridement and dressing change. And then we'll base that fluid resuscitation in the first 24 hours on that post-debridement TBSA. So lots of work upstairs. That's where they'll get the Foley, the NG tube. We'll start feeds. But really, our priority in the ED is just to get out, cover and get out, and some pain medicine. Here's just a quick example of modified Parkland. So as I said, major fluid shifts in those first 24 hours. But basically, we look at that post-debridement TBSA and the child's weight times 4. Half of the volume goes in the first 8 hours. The other half goes in the second 16. And this is very tightly calculated on our fluid resuscitation worksheet in the ICU. If they're less than 30 kilos, we will also run D5LR at maintenance, and that doesn't change. We wrote a guideline in July that patients with burn injuries should have feeds that actually don't stop at midnight. It's really safe to administer enteral feeds until 1:30 in the morning if it's a 7:30 case. So that was change number 1. Nutrition is of the utmost importance to the burn patient. By nature, they're hypermetabolic, so they really need those calories to heal. So that's number 1. We created a burn surgery NPO order set that also dictates that if a kid has tube feeds that end at 1:30, they can actually have clear liquid tube feeds thereafter until 5:30 for a 7:30 case. If they're in the ICU setting, ideally they have a post-pyloric tube, and those feeds can continue either up to or during the surgery. So feed the babies. Characteristics of accidental burns. So again, think of that mechanism of the little one toddling over, pulling that hot tea on themselves. What are you going to see? You're going to see asymmetric margins. You're going to see splash marks. Not occurring in multiples, I think of that like cigarette burns. You would see kind of multiple cigarette burns. And again, as the liquid runs down, you're going to see that the burn injury is usually a little less deep dermal. We wrote this guideline about 5 years ago that everyone in the ED with a burn injury who's less than 2 should have a social work consult. And again, that's just to screen for home safety and other risk factors in the home and just to make sure that families have all the resources they need. So complications following burn injury, as I said, the burn can immunosuppress the little one. So most kids right now are on the brink of a cold or getting over a cold or strep throat or something like that. So again, the burn injury can just kind of push them over the edge a little bit. We take fever very seriously. We ask that parents call us if the child has a temp of 101.5 or greater, and then very low threshold to bring them in. Once we bring them in, we want to fully expose the child. We want to do a good head-to-toe exam, look for otitis media, look for strep throat, listen to their lungs, but look at the burn as well. A lot of times people are a little wary of taking that Methylex AG down or taking that bandage down. We have to make sure it's not infected. So this is my plea to you all. If you have a kid with a burn that comes in, take the dressing down, redress, get the supplies you need, but we really have to make sure that the burn itself is not infected. Usually they're not. But again, we need to take a look. And every time I show folks this slide, I always say, I need to change this slide. This is a gross picture of what we call staph pustulosis, and I have to change this. You guys remind me to change this slide. I'm sure I can find a better picture somewhere. So what this is a staph infection. We know that staph lives on the skin. So sometimes in the summer months as kids are scratching, as the burns are healing, or it can even happen in the wintertime, bacteria can get under the skin around the burn injury and cause this yucky rash. Again, super important, again, if the kid presents with a fever or decreased PO or any concerns, take a look at that wound. What I mentioned on the slide here is wound conversion. It could be deeper, and that could be causing them to be sick. And then, of course, feeding intolerance. We want to make sure that, that we would stop feeds if they're experiencing emesis or abdominal distension. So we do have, if an admitted kid is running a fever suddenly or comes in with a fever, a burn fever or suspected infection order set. And this is really nice. Back in the day, we used to just pan culture kids arbitrarily at 72 hours. Now this is a workup that's guided based on symptoms. So urinary symptoms, guess what? You're getting a UAUC. If there's a concern for sepsis, you're just going to go ahead and start antibiotics after getting a blood culture. So again, this is really going to nicely guide you through that workup based on symptoms. And it also automatically has a hospitalist consult order in it as well. So most of our care, though, is in the outpatient setting. We admit about 90 burns a year, and the rest of that care is in the outpatient clinic at Children's National. So we have a clinic here Monday, Wednesday, Friday, and then an off-site clinic at Friendship Heights where we are on Wednesdays. About 20% of our visits are telehealth visits. The nice thing about clinic here is that it's a full-service clinic, meaning every resource the family might need, we provide in clinic. Whether it's Dr. Tully with psychology, Dr. Bird if there's a concern for a child needing surgery or a deeper injury, child life, PT, OT, you name it, they come to that visit. So lots of services that we provide here. Just another plug for the burn casts. As I said, we have, how many do we have, Joanna? 17? 18? 18. Okay, so the last two are about care in the ED and then that burn enteral nutrition protocol, if you have any questions. Lots of information about that. And as I mentioned, the after the burn videos, so these are all on the Get Well network. We created these in 2018, so we're definitely looking to make some updates as well, but a great reference for families to watch, whether it's, kind of summarizing the hospital stay or what are different resources, what is skin grafting, how do I get to burn clinic, how deep is a burn, etc. And that is the last slide. Any questions I can answer for you all? Perfect. Very good. Thank you so much.